Yep.
Fantastic. And you can see me changing the slides as well.
Scrolling through, yeah.
Yeah, great. Okie dokie. Let me just change. Great. Alrighty. Hi, everybody. I'm so sorry for being 1 or 2 minutes late just from my morning clinic, so apologies. But my name's Nathan Cantley. I'm a registrar working within the Bristol Lipid Services. And hopefully you're here to have a listen about the National Lipid Guidelines from the AAC, as well as hearing some themes about lipid-lowering therapy initiation and titration as well. Just as a declaration of interest, I've never received any honorary impairment sponsorship for any company producing medication in this talk, or participated or supervised any clinical trials of any medication included in this talk either. And we're really wanting to cover off a number of elements within clinical lipidology and how you guys within primary care, who do the vast majority of clinical lipidology that happens in the NHS, how we can support you as best as possible, both with treatment choices, titration options, and what's available. So it's now been around for a year or two now. It's in its second or third iteration, but the Accelerated Access Collaborative now have national guidance on lipid management for both primary and secondary prevention of cardiovascular disease. We've included that within our local remedy guidelines on lipid management. So this will be your first port of call to summarize this guidance. I also just want to flag up that they've created the AAC collaborative that published national guidelines also have an incredibly useful interactive tool that goes through primary and secondary prevention. And we'll actually cover quite a bit of what I'm going to be talking you through today. But what I want to try and add to what you can find on the national guideline .
Sorry, Nathan, you've gone on to mute.
That wasn't me. Can you hear me now?
Yes, yeah, you can.
That's fine. That wasn't me that put me on mute. So starting off with how do we measure cholesterol? So within primary care, the focus has been very much on HDL cholesterol profiles, especially within the primary prevention patients that you manage in the community. This has an advantage in that it trims down what the information you get to the non-HDL value, which as has been the dogma with the NICE guidelines on primary prevention, has been the focus of treatment targets. But there is a number of limitations whenever you're only dealing in relative terms of HDL and non-HDL. And the two crucial bits of information you miss is that triglyceride measurement and LDL cholesterol measurement. And so in collaboration with Medicine Optimization Group within the local ICB, with the ICE pathology ICE meeting group, as well as the clinical lipidologists within secondary care, we've decided to shift that requesting pattern onto full lipid profiles, because actually the emerging dogma about lipidology is that it's much more about the triglyceride and the LDL rather than just looking at non-HDL values. There are limitations to us moving to LDL, full lipid profile measurements. The mainstay being how we calculate LDL, which is something called the Friedewald calculation, which I will not bore you to tears about this afternoon. But LDL is a calculated parameter. It's not a measured parameter within the lab. So it's based off this equation that originated really in the 60s, in which we haven't changed since, of how you calculate LDL based on total cholesterol, HDL, and triglyceride values. But the equation breaks down whenever the triglycerides are more than 4.5. We're in the early stages of potentially updating the equation used for the LDL calculation to one of the equations that's been validated in extremely large, almost population-based cohorts. And there'll be more news to come on that later in the year. But in the community, if you have a patient in front of you where actually you want to know the LDL value, but the triglyceride is high enough that it's knocking it out, I would just want to signpost you towards something called the Martin Hopkins LDL calculator. It's available on both the Apple Store and on Android or Google Play Store. But essentially it's a calculator where, again, you use the total cholesterol, HDL, and triglyceride, and it gives you an LDL despite the triglycerides being high. Martin Hopkins is one of the more newer equations used for LDL calculations, and it's one of the options being considered. But in the meantime, whilst we're sorting our ducks in a row from the lab perspective, Martin Hopkins calculator is something that you can use now within the community if you have got one of those hypertriglyceridemia patients in front of you that you still want to know what their LDL is. Once we've measured cholesterol, and I should say the change to using full lipid profile only within BNSSG is now live. The next question is, well, what is regarded as normal? And cholesterol, as compared with a number of other biochemical tests, doesn't really have a normal range, so to speak, or it is one that there is a high amount of variation as you get older. The general trend is that your cholesterol values increase as you get older. And looking at pre to post menopause, there is a significant uptick in your cholesterol going from pre to post menopause. So establishing a normal range is sometimes difficult. One thing that might help you put it into context, setting aside some of the cutoffs that we might use for referral to the secondary care lipid clinic, if you're not really considering that, but really wants to get a sense of how typical the patient in front of you's cholesterol results are, there are some non-validated but tools nonetheless that can map the patient in front of you's cholesterol value against population data to give an estimate, and this link will be available in the slides shared after the meeting, that you can use to help put things into context. But I stress, still keep the cutoffs that we refer to for considering genetic dyslipidemia in mind, but just note that as you get older, your cholesterol values will go up physiologically. Now we've measured cholesterol and we've considered what might or might not be normal. The question then comes to, are you going to treat them or not? And the NICE guidelines have CG181, which is the main primary prevention guideline, has changed over time. It's had its most recent iteration actually within the last 12 to 18 months. And before, the dogma was, well, if your Q risk is under 10%, then your 10-year CVD risk is low enough that you don't have to treat their lipids, or it's potentially a decision that needs to be individualized to that individual. The dogma is changing. NICE hasn't quite caught up yet, but internationally, we're thinking more about lifetime risk rather than 10-year risk, which is what the dogma has been over the last 10 to 20 years. So whilst the NICE guidelines still do quote that 10-year Q risk of 10% as being a cutoff, it is much more, I would say, a soft cutoff rather than a hard cutoff, and for whether you should consider treating someone for primary prevention. And that soft cutoff comes from a number of caveats. QS3 and JBS3 are just two calculators that are trying to change that conversation about 10-year towards lifetime risk. But the nuance comes in part due to the failings of that risk calculation to begin with, and the fact that it uses this cholesterol to HDL ratio. That's a very outdated parameter now when it comes to clinical lipidology, whilst it's still being used within QRS3 equations. Now, there's a lot of nuance to expand out from what is meant by that cholesterol HDL ratio value. And if your HDL is very low or very high, then it's not really going to give you a very accurate sense of what their atherogenic cholesterol parameters are actually doing. So that is nuance number one. Variations in HDL will break down the validity of that ratio calculation. Number two, that ratio will potentially mask individuals who have very high LDL cholesterol, and I'll come back to why that's important later on. And three is that whilst it incorporates risk factors for cardiovascular disease like diabetes, the more wider published data there is about cardiovascular risk would tell you that really population health scores like QRIS is going to underappreciate the cardiovascular risk associated with those factors if they're present. So chronic kidney disease of stage 3 or worse, type 1 diabetes of significant severity over a significant period of time, QRIS is going to underappreciate the risk associated with that. And coming back to HDL and taking HDL to one side, the normal range for HDL is, again, slightly vague and slightly individual dependent, but we know two very definite cutoffs where your cardiovascular risk, based on the studies that have been published, will go up if it falls into either of these two categories, and that's where your HDL is below 1 or greater than 2.2 or 2.5. If it falls into either of those two categories, your cardiovascular risk is going to be higher compared with someone with an HDL that falls in between those two values. So again, that ratio will break down at that point. So number of caveats to do with the Q risk. So I would definitely ask you, if you're considering treating someone for primary prevention, that whilst you still use Q risk as part of that, consideration, that you think about the exceptions to that rule. And just to remind you that considering their HDL being outside of those two values, the length, duration, and severity of those other cardiovascular risk factors that are present, the consideration of whether or not a genetic dyslipidemia may or may not be present, the family history of cardiovascular disease, because whether or not there is a genetic dyslipidemia present, having one or more family members who have had premature cardiovascular disease increases your risk significantly. So a number of nuances to using that hard fast rule, which NICE is trying to soften that hard line on in its most recent iteration. So moving swiftly on then to what actual therapies you initiate, which again the national guidelines summarize really, really well. Our suite of statins has broadened over time, and I really just want to demarcate the statins you have available into two distinct sections. You've got the fluvastatin, pravastatin, and simvastatin, which will now very much be regarded as older generation statins. And if you have people in the community who notice either on medication reviews or on annual CVD reviews on either of those three statins, fluva, prava, or simva, please do change them onto at least atorvastatin at an equivalent dose. Because even at near enough the lowest dose, atorvastatin is regarded as a medium intensity statin. And actually, when it comes to high intensity statins, you start to branch into the high intensity statins, even at atorvastatin 20 or higher. So again, the central dogma within high intensity statins is that if you're going to start someone on a high intensity statin, it has to be atorvastatin 80. But that isn't the case and isn't the dogma. There are still certain cohorts where atorvastatin 80 should be your first line of choice if it can be well tolerated. But actually still consider those lower doses of atorvastatin still be at least medium, if not high intensity statins. Also want to just bring up about the titration point in a minute. But if you remember back to what the national guidelines are saying, it's telling you that your entry point is going to be 20 or 40 milligrams of atorvastatin, with the nuance and caveats being for those with chronic kidney disease, or potentially who have other risk factors for being statin intolerant to begin with, such as high ALT or liver function test arrangement, or individuals with a background myopathy or tired all the time presentation. So entry point, atorvastatin 20 or 40 in primary prevention. Titration. So in part, your titration comes down to, so I'm going to skip through my slides slightly. Your titration comes slightly down to what targets you are setting. So NICE guidance, primary prevention dogma has always been consider a 40% reduction in the non-HDL from its baseline. Again, the messaging around primary prevention, certainly from ourselves within secondary care lipidology, is trying to change that notion about relative targets, because again, in those nuanced categories, like individuals with genetic dyslipidemia, strong family history, strong personal history of CVD risk factors, you're going to want to try and treat them more intensively. And the European guidelines on lipidology and treatment titration will very much be the notion of lower is better earlier, which on a population level, that messaging is not appropriate. But in those individuals which you are seeing in front of you, that you're treating for primary prevention, that is a subset of population of the population that will need to be treated intensively. And rather than looking at relative targets, I would urge you to consider thinking about absolute targets, specifically in those who have one or more risk factor, thinking about an LDL of 1.8 as your minimum of where you treat to, be that primary or secondary prevention, and thinking about lower targets such as 1.4 or higher in those who have multiple risk factors and have cardiovascular disease or other atherosclerotic vascular disease present. And document those targets within the clinical notes whenever you're seeing them for their annual reviews. The rationale for us thinking about lower is better earlier, I'll come to in a minute. But to tie off the conversation about statin choice and titration, the main point I want to bring you to and highlight to you is whenever you look at going across the table horizontally versus vertically, or thinking about the atorvastatin versus atorvastatin plus ezetimibe, or rosuvastatin versus rosuvastatin plus ezetimibe, what you'll notice is that doubling up the dose of the statin will get you potentially an incremental change of 5, 7, and potentially maximum 7 or 9%. Whereas if you look at the equivalent dosing between atorvastatin and atorvastatin plus ezetimibe, you're getting near on 10% flat at your basis, adding in ezetimibe, especially at the lower doses. So treatment titration is a very difficult topic to get and to have a streamlined pathway. It's very individualized. It's very much based on the patient in front of you. But more and more, we're trying to encourage thinking about what's your most optimum one-step optimization, i.e. going from an entry point to their potentially maximum tolerated oral lipid-lowering therapy. And if you've only got one option or one opportunity, I would urge you to consider whether or not you add on ezetimibe to whatever maximal statin dose you've been able to reach, and to get that little bit more from your oral lipid-lowering therapy, because you'll get much better return. And we'll come back to statin intolerance and back to this little table in a little bit. The other point when it comes to titration and going between different treatment targets, and something that within the laboratory side we don't explain very well, is this concept of measurement of uncertainty. So every value that is produced by the lab will have a degree of uncertainty around it. It will have confidence intervals around that measured result, because anytime that we take a snapshot blood test, we're only ever really getting a snapshot within someone's natural biological variation. That's the natural swing of someone's biochemistry throughout a 24-hour period. So around the point measurement, we'll have these confidence intervals, and you'd be surprised how much those intervals overlap. And an age-old question is, someone's cholesterol's gone from 1.4 to 1.8, or 1.6 to 1.8. Is that a significant relative change? And large in part, a difference of 0.2, 0.3, 0.4 millimoles per liter between two values shouldn't be regarded as a significant change. But what I would say is that if you've got someone who's in the mid-2s and their treatment target is less than 1.8, that's whenever there will be a significant relative change if you can get them down to target. So small, tiny changes of 0.1, 0.2 millimoles per liter, potentially not clinically significant. More than 0.5 millimoles per liter, much more significant. That's why sometimes we try not to focus too much on the difference between 1.4 and 1.8 in the majority of individuals, but getting down at least to 1.8 or less is a really important treatment target to have in your mind. And if you're ever wondering at the back of your mind with the patient in front of you whether or not two results that you have on a patient are actually that significantly different, BMJ produced this really good interactive tool not too long ago that I would encourage you to use, because it's actually got some really good visual representation of the difference between two values. And you can take real world data, the patient you have in front of you, and plug it into the tool and get your answer on whether or not their cholesterol is significantly changed or not. So I use it sometimes whenever I'm trying to explain things to patients. Okay, so we've talked a bit about treatment titration, but why am I putting forward to this message contrary to the NICE guidelines, which still purport, a 40% relative change in non-HDL for primary prevention, no matter what? And really, this is again another example where NICE is behind the curve, and why the European guidelines and American guidelines and numerous other international guidelines are putting forward this message. And there's two really important concepts that I think is worthwhile to bear in mind whenever you're considering lipid titration. One is cumulative LDL. Okay, so a question we sometimes get asked through advice and guidance is, I've got someone in their 30s or even in their late 20s who has high cholesterol. The Q risk is coming out as less than 1%. They've got a bit of a family history, but should I be treating them now, even though they're only in their late 20s or early 30s? And this notion about cumulative LDL exposure is a perfect example of why the answer to that question should really be yes. Because if the systematic reviews, the meta-analysis data, of which we now have tons of across all the trials and studies that there have ever been done on cholesterol, will tell you that as someone's cumulative LDL exposure increases, i.e. the number of years that they have a cholesterol value at a certain level, your hazard ratio for cardiovascular events will steadily go up. So if you've got someone in their 30s who has an LDL cholesterol in the 4s and 5s, and you leave them there, and then they will have a higher chance or risk of cardiovascular disease than someone who's developed that same LDL cholesterol in their 40s. Okay, so cumulative LDL exposure is a concept I want to put forward as a reason to be treating to lower targets earlier, to try and flatten off that curve for the patient in front of you. Another kind of spot fact that we sometimes use within lipid clinic whenever we're trying to help explain to patients why you want to treat their cholesterol. Again, meta-analysis data, pooling data together has helped demonstrate that for every 1 millimole per liter LDL you reduce by, you yield a 23% relative risk reduction for CVD events. And that's for every 1 millimole from their baseline that you're able to lower by. That relative risk is super added for each millimole you knock off, and it extends over a significant period of time as well. So rather than that relative risk reduction only happening for the first year, 2 years, it happens well into the 10 or 20 year time frame. So that second point tells you why lower is better, because each 1 millimole per liter, you get a 23% relative risk reduction. And the cumulative LDL theory tells you why getting you down to target earlier is better to try and reduce that cumulative exposure. The other flip side to it is the data we have from cardiology services, and this is to do with plaque morphology, which I don't want to get into the details too much of about how a coronary artery plaque forms and develops. But the earlier that you are able to reduce someone's cholesterol, or the earlier in the life cycle of that coronary artery plaque, you're able to start reducing someone's cholesterol, the more chance you have of being able to halt progression of any plaque that is there, and potentially, if it's early enough, reverse any early atheroma that is starting to develop. In the late stages of coronary artery plaque, the best you can hope for is for stabilization of coronary artery plaque. But in the earlier stages, and this is why we come back to that example of someone in their 30s who's maybe already had 5 years exposure to a high LDL cholesterol, you want to be treating them then rather than putting it off for another 5-year or 10-year review and considering lipid-lowering therapy at that point. So UK position, very conservative for primary prevention. Hopefully the data that I've just shared with you puts forward a case of why we need to try and get more into a habit of treating lower earlier. Balancing that against medication burden, absolutely. But actually, if we can stop someone from ever having a CVD event by treating them early enough, then that is actually a good use of healthcare resources. Secondary prevention. Now, secondary prevention has typically had a very strict definition of someone who has had acute coronary syndrome or a CVA, including TIA of a stroke. But actually, secondary prevention, the definition again is changing over time and it's becoming more nuanced. Those who have angina, that is absolutely going to be someone who's already symptomatically demonstrating that they have coronary atheroma burden, and it's giving them symptoms, not to the point of an ACS, but still to the point that we need to be preventative rather than reactive. Similarly, peripheral arterial disease represents someone, the old hat term is maybe a vascular path, but someone who has predispondency to develop vascular disease, and whereby if we treat their cholesterol, we can potentially help halt or change the progression of that peripheral arterial disease. And it's been something that has crept into practice more and more, but using CT coronary arteries, coronary angiograms to pick up asymptomatic coronary artery disease is still a population whereby you want to be treating them as if they're secondary prevention patients, because those are patients who are in a much higher risk category or of either new or future cardiovascular disease. So think about broadening that definition. And again, it speaks more to this more of a sliding scale when it comes to CVD risk, rather than people fitting neatly into either primary prevention or secondary prevention. The treatment dogma has always been, start with the atorvastatin 80, and for the vast majority of people, that should still be the tradition. But the nuance that we want to bring into it is that you may have individuals in front of you, very, very poor treatment compliance, very, very poor treatment concordance, who have a wide variety of adverse effects from medications not related to statins whatsoever, where we want to think about alternates. And I would put forward to you, bringing back this statin initiation table, of considering either a slightly lower dose of atorvastatin with ezetimibe as an adjunct, which, as you can see from the little table, will give you as good an LDL reduction, but potentially might not make them in a group of individuals highly likely to develop adverse side effects, and may help with treatment compliance and concordance. Similarly, rosuvastatin, it was on patent for a number of years and so very expensive, but is now off patent and not actually that much more expensive than atorvastatin. And so we're using that much, much more as our second line statin. And as you can see, even at the lower doses of rosuvastatin, then you're getting high intensity LDL reduction. So moving on to statin intolerance in a minute, these sorts of nuances is what we want to consider. in our lipid-lowering therapy choice. Within the remedy guidelines, we do have a second prevention pathway, and your options for titrating therapy over and above that simple atorvastatin 80 message. There's 3 options available to you. The middle option, I recognize, and it would be remiss of me not to acknowledge the conversations that have been had about inclisiran over the last couple of years, because I realize that there is a breadth of opinion on the appropriateness of using inclisiran as part of this pathway. For those who haven't come across inclisiran, it is a PCSK9 agent. So PCSK9 is a protein that recycles the LDL receptor present within the liver that helps take up LDL cholesterol from the peripheral circulation. So if you cancel out PCSK9 activity, you allow the LDL receptor to be functioning for longer and therefore get better LDL removal from peripheral circulation. So PCSK9 agents like inclisiran, inclisiran is a newer mechanism of action of achieving that outcome through silencing RNA therapy, but it, like the monoclonal agents that we've had for a good 10 or 15 years now, works on a common factor. The Orion 10 and 11 trials are the main clinical trials that have highlighted the effectiveness and the clinical effectiveness in inclisiran in reducing LDL, with the difference being of roughly 50% LDL reduction in a single agent, which is very effective and just as effective as monoclonal antibody agents, which need to be taken every 2 weeks, versus inclisiran, which is only required twice a year through a subcut injection. The controversy around inclisiran that it would be remiss of me not to acknowledge has been about the long-term data. Orion 4 is the long-term safety data trial, which is due to be published in the next few years. And understandably, there have been feelings amongst leaders within primary care and other companies about introducing inclisiran into pathways prior to the Orion 4 study being published. Main counterpoint to that is that LDL theory has been around for many, many years. From the point of statins, we've established the direct link between lowering LDL and cardiovascular outcome. That's not an associated link, that is a direct biological link between lowering LDL and reducing cardiovascular events. Secondly, the healthcare costs of introducing inclisiran versus trying to prevent a further CVD event favors more in inclisiran versus potentially not utilizing it, because we know from local data, even within this ICB, that there's a large cohort of individuals who should be treated for secondary prevention but aren't receiving anything at present. So this is a cohort that we really need to find these alternative options for, of which inclisiran is one of them. I don't disagree, and actually I do agree that some of the interventions that were taken by healthcare leaders nationally at the time of inclisiran's introduction did not help with reassuring primary care that it had been introduced for the right reasons. But all of the data that we have about the effectiveness of LDL lowering, the safety data from the Orion trials that have been published thus far, would suggest to us that this is a safe and clinically effective treatment, of which Orion 4 should only back up rather than produce surprises from. The monoclonal side to PCSK9 inhibition, as I say, has been around for a number of years, is currently red and amber within, red within our ICB. So it is done on secondary care prescription at present. But it would be perfectly reasonable if you are seeing someone in the community who should be treated for secondary prevention and where you're really struggling with lipid-lowering therapy, that you consider pathways that will help utilize monoclonal PCSK9s as an alternative therapy. The Fourier and Odyssey trials for evolocumab and alirocumab yielded a similar LDL reduction of about 45–55% in LDL, and did show good endpoint data for cardiovascular endpoints. So we've been using it within the secondary care liver count for a number of years, and would be a good and reasonable indication for advice and guidance or potential referral to the liver clinic in the populations where it is indicated. And this is the summary from the national guidelines that highlight those indications. Then for those that sit within an LDL of 1.8 to 2.5, where injectable therapy isn't available, it's another reason to consider ezetimibe if you haven't already as part of their lipid-lowering therapy. Ezetimibe has been around for years now. It's an inhibitor of the Niemann-Pick-like receptor within enterocytes, and essentially it helps inhibit dietary cholesterol absorption into the peripheral circulation. It's not very effective as a monotherapy in yielding only a 10 to 15% LDL reduction, and can yield GI adverse effects. But as I've shown within the table, both for atorvastatin and rosuvastatin, it is a really good option to consider as an adjunct where otherwise injectable therapies aren't available. Statin intolerance then. I realize I'm throwing a lot of information at you, and very, very happy to answer questions at the end. But in terms of statin intolerance, again, we have a national pathway, a nationally agreed pathway for how to deal with statin intolerance. And at first glance, looking at that, I would not blame you in thinking, oh my lordy, that's a lot of steps for us to try and consider in primary care. But really, if we were to simplify it into two main categories of individuals that you will see in primary care, there's those where statins are very likely to still be on the table at some point. It is more time intensive, and those represent the vast majority of individuals, but could be kept down to 3 discrete steps if you were to consider, if you've got a patient in front of you or you're considering statin intolerance. First step being de-challenging whatever statin therapy they're on, or at least de-escalating. And I say, I put in that point about de-escalating rather than de-challenging, because for those who you're treating for secondary prevention, it is much better to do a swap of a medication rather than taking them off medication completely, as that can have an adverse outcome for any background atherosclerotic disease that you're trying to keep at bay. And so in secondary prevention or very high risk individuals, think about swapping rather than de-challenging and re-challenging. And your options are either, whenever you re-challenge or you swap them, thinking about a lower dose of the same statin or an equivalent dose of a different statin, coming back to atorvastatin and rosuvastatin as your 2 main options. And whichever option you try, thinking about ezetimibe as an adjunct to achieve your equivalent LDL. And that might be in those who have that category of options. You think of individuals who have really non-specific symptoms, which I appreciate comes with a high prevalence within the primary prevention population, or individuals who don't have any objective symptoms or objective biochemical markers to suggest statin intolerance. The other main group of individuals where statins aren't on the table, either because you've already tried rosuvastatin and it's not worked, or the lowest dose of rosuvastatin and it's not worked. That's whenever you need to be thinking about those other options on the table. For primary prevention, you might consider a medication like bempedoic acid. For secondary prevention, thinking about either monoclonal or inclisiran, PCSK9 therapy. And certainly it's an indication for lipid advice and guidance if you're thinking about how someone falls into those 2 categories and what option you go for. Main thing I want to highlight, and sometimes an easy win, within the group of individuals who get statin intolerance, sometimes we hear people talk about brain fog, lack of concentration, on a sleep disturbance as an adverse effect in the atorvastatin. And a very easy win is if you directly swap them to rosuvastatin. The reason being that atorvastatin crosses the blood-brain barrier as a result of being lipophilic, whereas rosuvastatin being hydrophilic doesn't cross the blood-brain barrier. So if someone is describing that adverse effect, think about that as potentially an easy win. And certainly within LipiClinic, that has been an easy win that we've been able to go to with good success. Again, I want to just highlight, if you're thinking about primary prevention and thinking or considering about bempedoic acid as an option, actually, you still get more bang for your buck if you go for even the lowest dose of rosuvastatin 5. Bempedoic acid, maximum 26-30%. LDL reduction on average. Rosuvastatin, almost 40%, even at the lowest dose on average. So I would still really point you more toward even trying the very, very lowest dose of rosuvastatin, even at a less than once daily dosing, as an alternative to considering bempedoic acid. The other reason, and apologies for flipping back through slides, but one thing I didn't present from an earlier slide was this slide here. Treatment compliance and concordance is such an important component of statin intolerance. Atorvastatin has a half-life that is variable, but is shorter compared with rosuvastatin, but is at least longer than simvastatin. The older statins were very much very short half-lives, clear from circulation quickly, and the preclinical data is saying that most of your HMG-CoA reductase enzyme that statins block, the majority of that activity happening overnight, meant that a lot of the dogma surrounded nighttime dosing of statins, but actually the longer half-life of atorvastatin and rosuvastatin, and especially the long half-life of rosuvastatin, means that please consider switching everyone to morning dosing by default if they take the majority of their other medications at that time, as it will be just as effective and might help with treatment compliance. But B, because of the very long half-life of rosuvastatin, it's suitable to be taken at even less than once daily dosing. So for individuals who are even struggling on rosuvastatin 5 milligrams every day, taking it every other day or even a couple of times a week might still yield good LDL reductions. But the higher their baseline and the higher their risk, think more about the non-statin based therapies as options. Apologies, going to flip back through my slides to where I was before. Bempedoic acid, very brief list of mentions about that as an option. It is blue on the BNSSG formulary as an option for statin in those who are completely statin intolerant. The reason why it works is that rather than blocking HMG-CoA reductase, an enzyme that operates both within skeletal muscle as well as other organs, bempedoic acid blocks a different enzyme called ATP citrate lyase, which again is within the cholesterol synthesis pathway, but a more downstream step that is only present within the liver and kidney. That is why it is a good potential option and won't yield the muscle myopathy that can happen with statins. It's worthwhile just making a note about individuals in front of you who have risk factors for statin intolerance, and that can be the older individuals who have other very common non-cholesterol based factors such as hypothyroidism, personal history of intolerance, vitamin D deficiency, dehydration, excessive alcohol. All of those are other reasons why patients might coincidentally get exacerbation of any symptoms around the time of starting or titrating a statin. And think about those other factors before you stop or start changing their statins, as those again might be easy wins to consider to keep someone on their lipid-lowering therapy for longer. I realize time is marching on, so these next couple of topics might be briefer. Triglycerides. With our change to full lipid profile requesting within the ICB, you will start to see hypertriglyceride values in patients that you review. And the important factors to consider are those checkpoints of 10 and 20. 10 and 20 are the two main checkpoints to think of. The normal range is only up to 1.8. So it's very common to see people with mildly elevated triglycerides. The main things that you want to consider are secondary causes like diabetes, alcohol excess, obesity, hypothyroidism. Think of all of those as reasons why their hypertriglycerides might be high. And rather than needing to make further changes to their lipid-lowering therapy, manage those secondary risk factors first. But where their triglycerides are more than 10, or more than 20, consider those more specialist reviews or consider adjuncts to statin therapy. And your adjunct therapy with triglycerides are fibrates. Think about fibrates if you're trying to deal with triglycerides. Statins are actually quite ineffective for individuals who have a triglyceridemia-dominated dyslipidemia. If they have LDL-dominated dyslipidemia, yeah, statins, think about statins first line. In triglyceride-dominated dyslipidemia, think about fibrates. And your important prescribing things to consider is in renal dysfunction, consider a pediatric dose, which is 67 milligrams instead of the standard 160 milligrams. There is a higher dose of fibrates of 200 milligrams once daily, but the data would tell us that there's minimal gains to get from choosing the 200 milligrams over the 160 milligrams. And actually, the only difference between 200 milligrams and 160 milligrams is the preparation itself rather than the effectiveness in triglyceride lowering. Also important just to consider not co-prescribing with statin doses above atorvastatin 40 or higher, and not co-prescribing with ezetimibe, as that can come with a theoretical risk of gallstones. Again, the remedy guidelines are very clear pathways of how we manage hypertriglyceridemia, the main goal being to try and prevent the onset of acute pancreatitis. But again, if you have an individual in front of you, you're struggling to manage their triglycerides, lipid advice and guidance would be appropriate to consider. Our referral criteria to the lipid clinic include everything that we've talked about thus far: individuals not able to reach target, hypertriglyceridemia, statin intolerance, considering familial hypercholesterolemia or genetic dyslipidemias, and those contexts are all outlined in the remedy guidelines and how to access them. The point I want to just touch on briefly is genetic dyslipidemias. There's been a lot of conversations about pathways, about how we help facilitate genetic testing within primary care. And I think my understanding is that that's been set aside by genetic requesting originating from primary care in this region. However, we still want to be giving you the tools to be able to pick up on these individuals in the community who maybe need to be considered as highly suggestive of familial hypercholesterolemia, the monogenic condition associated with elevated LDL cholesterol. The FH Wales tool available online allows you to input clinical information about the individual in front of you from their family history, personal history, and their treatment history and their cholesterol values. And on the screen are some of the cutoffs that we use for thinking about familial hypercholesterolemia to be likely. This is being introduced to a degree in part within our referral forms through ERS to the lipid clinic. But if you're kind of at a stage where you're trying to think whether or not to do an ERS about someone you're considering a genetic dyslipidemia in, the FH Wales tool can be helpful for that. Final point I just want to consider is lipoprotein A. I don't have time to go into this in a lot of detail. Lipoprotein A is another arthrogenic lipoprotein. It's made out of LDL and another lipoprotein called apolipoprotein little a, which makes it both pro-arthrogenic and pro-thrombotic. At present, it's still largely tested for in the secondary care setting in individuals who have a highly suggestive history of premature cardiovascular disease. But we have clear guidelines that if you have someone who is being tested in secondary care and onward actions have been suggested from a clinic letter, that we have very clear guidance on how you in primary care can help support that individual and that individual's family. And if you have any questions about that, I can go into more detail. I've tried to cover quite a lot of different topics within this presentation. I could use a couple more hours of your time if we had enough of it. but we have a number of different approaches that we can take now for lipid lowering initiation and titration. And we are here within the Lipid Clinic to help support you with those options as you need it. But our national guidance is becoming clearer and clearer about how within primary care we can make the most for our patients. Thank you very much for your time, and happy to take any questions.
Excellent. Thank you, Nathan. That was very interesting and informative as always. So there's lots of kind of useful, practical information in there. There's quite a few questions in the chat, and we've got 5-6 minutes left. So I guess we'll try and get through them as quickly as possible. I'll read them out for the purposes of the recording. So first one, when is LDL considered too low, and what would we need to do regarding the statin? Had a patient 0.4 on atorvastatin 40.
So the data will tell us that there is no lower limit at which LDL lowering ceases to give benefits for cardiovascular risk reduction. There is small signals of data within paper suggesting that LDLs of less than 0.1 might confer an increased risk of hemorrhagic stroke. That data is very, very limited. And I would tell you that physiologically, we only need LDL values of between 0.2 and 0.5. That's our physiological set point of where our LDL sits. So if you have someone who their LDL is sub 1 or 0.5 to 1, completely safe. Less than 0.5, start to consider titrating therapy back. But it's only really as you approach 0.2 or lower that I would really start to try and pare therapy back. And rather than treatment cessation, because if you're treating someone down that low, they're potentially going to be someone who's high risk. Think about more paring back, just going one dose down on the statin, because that LDL increase that you'll get from lowering that statin dose by that amount will probably be enough to lift it into that greater than 0.5 category. So for that exact example of 0.4 in the atorvastatin 40, try them on Torva 20. And you're still very, very likely to be well below the 1.4 target, even if they're a high risk individual, and still be very, very safe.
Thanks. So next one, female, 58, strong family history of high cholesterol, mum, sister, grandma. Grandma had an MI at 63 years old. Total cholesterol 7.79, previously between 5.4 and 6.6.
Yep.
LDL 4.65, triglycerides 2.85.
What you like. So that is someone who I would place in the high risk category, of someone that you want to be at a minimum treating them to a target of less than 1.8, and that I would take that as the first key point. I would potentially, now that we've come to the end of the presentation, point you towards that FH Wales tool about just bringing together, looking at their biochemical history. If that's seeing their past tests well into the 5s, they're someone who I would be having high signals for, considering a genetic dyslipidemia. So I would also point you towards the FH Wales tool and consider a lipid clinic referral, but definitely treating them to a less than 1.8 target with all that we've said. I've got the questions in front of me, so I can go through them with you. Next question, with coronary artery calcification, is incidental finding on imaging be an indication to start primary prevention? So if someone has coronary artery calcification, that is a very common finding in those, certainly within their late 50s, early 60s, a small degree of coronary artery calcification becomes more and more a normal finding if you were to screen every person within that age category. But it does in itself point towards someone who has at least got some atherosclerotic plaque, and that's been there for a while. So I would definitely start them for at least primary prevention if you're picking up on coronary artery calcification, because that's probably telling you that they have got coronary artery atheroma elsewhere, even if the limits of their calcium score hasn't laid that out in full. So I would at least treat them with primary prevention, if not consider secondary prevention targets. What are most common side effects reported on inclisiran? So it's mostly injection site reactions. We've now had a couple hundred people on inclisiran, and we've had to stop it in a handful of people. Could probably count on 2 hands the number of people have had to stop, but it's mostly been injection site reactions or any allergic reactions. and that sensitivity reactions that people can get with injectable therapies. And so injection site reactions would be your number one thing to consider, but really there aren't any other significant adverse side effects reported. Question about liver. ALT is more than 3 times the upper limit. And do not start, but what if ALP is raised? Do we have no K limit to start weight? Not specifically, but ALP in itself can be another indication for liver-based dysfunction after a statin initiation. The cause behind it is what I would signpost you to. Individuals who have NAFLD or MASLD, as we're now meant to call it, non-alcoholic fatty liver disease, those individuals will benefit from having their cholesterol lowered. So if the main reason why their LFTs are elevated because of NAFLD or MASLD, potentially still try and push through with either the same dose or a slightly lower dose. ALP, think about the 2 to 3 times the upper limit of normal. If you're more than 2 to 3 times the upper limit of normal, which would be an ALP of about 400, 500, really start to consider the risk benefit of continuing the statin. But it's really making sure that you've thought of other reasons for that liver dysfunction. And I'll answer one more just because I realize it's going on 1 o'clock. Why would you not consider a combo of bempedoic acid and ezetimibe in secondary prevention? So joint lipid guidelines even consider it as an option. So I think it's something that can be considered, but it's just not very effective. So, as I say, the maximum LDL reduction you will likely get is roughly 30% on average from baseline. So it's not that it can't be an option to consider, but there are just a lot more better options rather than that to go for. As I say, lowest dose of rosuvastatin or injectable therapies. So that is why. I'll stop there because it's exactly 1 o'clock, but I realize there's 3 questions that I will absolutely get the details off and reply to by email if we can get them.
Yes, yeah, excellent, thank you. So, yes.
Sorry also for talking very quickly.
No, as you said, it's a shame we don't have another couple of hours to go through this in even more detail. But yeah, just to sign off, thank you very much really to you, Nathan, for giving your time and expertise. It's been very insightful and very useful. So we hope everyone else found it very useful and informative. There's a feedback form link been shared in the chat. So if you'd like to give some feedback, then we welcome any feedback. And that is it. So thank you everyone for coming, and I hope you have a good afternoon.
Thank you very much.